Welcome, everyone. I'm Ron Brookmeyer, Dean of the UCLA Fielding School of Public Health, and I'm thrilled to have you join us for the inaugural webinar in our series called Fielding Focus. The onset of COVID-19 has brought into stark relief the many imbalances that previously existed in our society, and in many cases, exacerbated them. We understand now more than ever the fragility of our world. Yet, this is not the time to sit back and despair. This is the time when we must work together to identify what ails us and find new ways to take action. In that spirit, and especially during this time of physical distancing, we will regularly come together like this, share information and ideas, and problem solve. It's my hope that you'll continue to join us. Tonight, we'll learn from our esteemed panelists, Jill Martin, Ozzie Martinez, and Eugene Schneller, about the intersection of COVID-19 and healthcare management. I'm so grateful to Professor Leah Vriesman for inviting our guests and moderating today's event. Leah serves as Executive Director of our school's executive programs in the Department of Health Policy and Management, and she is also co-director of our school's Center for Healthcare Management. And before I pass it off to Leah, a quick mention. Next Tuesday, on March the 5th, Professor Jessica Gibson will lead a discussion about the toll that COVID-19 is having on vulnerable populations. And on May the 12th, Professor Michael Prelep will moderate a panel taking a closer look at COVID-19, wellness, and healthy living. For now, it's my pleasure to pass it off to Leah, and let's talk about COVID-19 and health care management. Leah.
Thanks so much, Ron, for the great introduction and kicking off our series here. I really look forward to hearing from our panelists and being a part of the Fielding Focus webinar. I'm looking forward to kicking it over to them, but I just want to make a couple of housekeeping requests for the participants on the webinar tonight. First of all, we want to let you know that this is being recorded and that the session will be available at a later time on the Fielding School's website. Secondly, we encourage questions from the audience. You will notice that you can submit them anytime through the Q&A panel, and we will be looking through those, and later after the panelists have spoken, we will take some time to answer those questions. I don't believe that you will be able to see your Q&A, but we as hosts and co-hosts can see them. And then finally, if you would like to tweet during this event and give us both the recognition and start a conversation, you can use one of two or both hashtags, either hashtag UCLA FSPH and also hashtag UCLA Fielding Focus, as you can see on this title slide. So the way we've organized tonight is I plan on briefly introducing our three panelists. I could say a lot about each one of them, but we're going to give them approximately 5 minutes. They'll each have a few slides to go over to bring a particular focus tonight on COVID's impact on healthcare management and what's going into health services delivery and the supply chain. You've heard a lot about those things, but I want you also to know that these folks have a very particular angle on it. They've studied it and they're living through it as leaders of their own healthcare organizations. So to start us off, I would like to introduce our first panelist. His name is Eugene Schneller. He is a professor and supply chain expert at Arizona State University. He currently serves as a principal investigator for the Department of Defense's efforts to innovate military healthcare logistics. So he's very much in the middle of the healthcare supply chain knowledge, and also the crisis that's been going on in our supply chain, given that the Department of Defense and the VA together, they operate one of the largest healthcare systems, 9.4 million beneficiaries, served by almost 900 treatment facilities worldwide. So Gene is very well versed in supply chain and what it takes to keep it going for such a large number. His consulting and research focuses on healthcare policy, best practice adoption, supply chain purchasing strategy, and even human resource development and supply chain integration within our health services delivery. I'm also happy to report that Dr. Schneller will be at UCLA in the fall as a visiting professor during his ASU sabbatical. So welcome to the UCLA family. Thanks for being here. Gene, I'll turn it over to you.
Thank you very much, Leah, and thank you for inviting me to be with you today. I come at this from a perspective of management and a perspective, I think, of healthcare policy and public health, and I'll try to bring some of those together. But let me just sort of frame this from the beginning as a discussion of a healthcare system that seems to have two problems. One is resource dependency. A hospital makes almost nothing of what it uses, and I'd like you to think about that, because I can't think of another organization that we could say that about. And secondly, the whole idea that Elinor Ostrom came forth with before in winning a Nobel Prize, the issue of the tragedy of the commons. And if you remember from your economics course or other courses, the tragedy of the commons basically posits that if we don't share resources, probably somebody's going to gobble those up and many, many people will fail. So let's go to the next slide and we'll see how that applies. So first, I would suggest to you that we really faced, as COVID-19 came about, a perfect storm. Mergers and acquisitions in the United States had led to a depletion of beds from about 1.5 million a decade and a half ago to 900,000 beds. And beds have been a major issue. Second, if you work with hospitals and integrated delivery systems around the country, there's a very strong focus on cost, lean, and just in time. And that has really led to hospitals really minimizing the amount of supply they have. We've moved a great deal to outpatient settings, and supply chain in many of the organizations that I deal with is seen as a revenue center. At the end of the year, the CEO says, did you take another $1 million out of it? And how did you do that? And by the way, one way to do that is to reduce inventory and basically go to a just-in-time and lean perspective. And we've talked about community benefit. But one of the things we've learned is that community benefit and public health benefits seem to be quite different. And finally, if we think about provider organizations, they've outsourced a lot of their risks for purchasing to group purchasing organizations and distributors, and frequently gone towards sole sourcing. So that's the first part of what I think of as a perfect storm. Secondly, we think of suppliers. And suppliers have now outsourced components, if not full products, abroad, much of those to Asia. And basically, they haven't looked at the relationship between the full products that they purchase, whether it's a ventilator or some other product, and their relationship to their tier 1, tier 2, and tier 3 suppliers. Very few of those organizations make the entire product. And therefore, there's been a failure to understand their own suppliers' risks, and single sourcing has led to problems. Next slide, please. So the perfect storm continues because we look at intermediaries. We look at group purchasing organizations, and for those of you who are in provider organizations, approximately 80% of your spend probably is going through a group purchasing organization. And therefore, you've outsourced contracting, you've pushed cost reduction on those. And one of the ways that they've tried to work with you is to get you to reduce your supply base. And therefore, you have even fewer products and frequently sole source products. And the distributors have done much of the same. To meet customer demand, they've gone toward lower total delivered cost. They've tried to reduce their own inventories, and that's been a huge problem in contributing to the storm. And then regulation. Scope of practice laws have restricted the number of individuals within a hospital or within a healthcare system who can do things. And accreditation and professional societies have really made us very lean in terms of the healthcare providers that we have. And finally, and perhaps most important here, a separation of public health from everyday health. And for public health, I include not only the large stores that we have that are done by Homeland Security, but also the stores by the Department of Defense. Next slide, please. So going forward down the road, what are the things that if I were a manager, I'd want to be able to do? Well, one would to manage this dependency. We are going to see over the coming months suppliers and small business failure. Sometimes these will be second and third tier suppliers, and we don't know who they are, we haven't tracked them, and we need to think about how to manage them and make sure that they stay in business. So there also needs an set of incentives to collaborate, but collaboration is going to the organizations, and if I were a supply chain manager today, I would be looking at my most vulnerable suppliers, both tier 1 and tier 2, and trying to understand their financial health and maybe investing in them, which is very important. Governance, federal and regional and local. We still have debates over how centralized stocks should be and where it should be. I think one of the things we've seen, particularly looking at New York, is the ability of regions to collaborate to bring together different kinds of supplies, and that's important. The issue of financing safety stock is one that's almost never discussed within hospitals, and hospital managers haven't thought about that. And we have a national stockpile of $7 to $8 billion worth of stock, and how that's managed is something we've given relatively little attention to. And therefore, there have been deliveries of products out of that national stockpile. Sometimes they don't work, sometimes they've had mold on them, sometimes they haven't been rotated. So we haven't taken a supply chain perspective in looking at that. And then hospital associations basically have become somewhat less powerful as we've seen mergers and acquisitions and large systems in competitive environments. And I guess finally here, and this is the drum I frequently beat, education for supply chain management in most schools of public health, most schools of public administration, and most schools of health management policy are really not treated around issues of pandemics. They're treated as how you develop a less costly and more efficient supply chain rather than one that's resilient. Next slide, please. So going down the road, a number of things we need to do. One is to be able to manage that commons. And that's coming to grip with the amount of competition versus collaboration that we see within our environments. And a number of online apps are being developed by companies to be able to have much more transparency within the healthcare supply chain. And by the way, one of the things that we learned from Hurricane Maria is that many products were sole sourced in Puerto Rico. We couldn't get bags, for example. The American Red Cross could not get bags to be able to go out and collect blood. All those bags were being made in one plant in Puerto Rico. How you come together to collaborate and support the supply chain is important. And what we've begun to see is a good deal of hoarding. And I believe that we'll see over the next few months that many hospitals have perhaps too much supply because they've tried to anticipate what would happen. It hasn't affected all hospitals. COVID-19 hasn't affected all hospitals around the country, but those hospitals are building up stores. And therefore, we don't have transparency and increasingly a lack of trust in terms of what government will do. And finally, we need to learn from other industries. At ASU, we've been trying to pull together a group, an industry advisory board, and we have companies on it that are major healthcare companies, but we also have companies on it that are major industrial companies. We look at companies like General Motors, which is expert at knowing where all of their supplies are, being able to track those supplies to all parts of the world, and going out and bringing those back quickly to be able to deal with kinds of problems that emerge within their environment. Next slide, please. So what I've tried to put forth is a supply chain perspective of a system that really was hit by what I've described as a perfect storm. I think we will see coming down the road over the next 3 to 5 weeks shortages of products that we didn't anticipate because we have focused so much on PPE products. And we really begin to need to take a supply chain perspective of the public health environment. So let me stop there. I welcome your questions. I know this is a little bit different perspective, but it's a perspective that I think is really important as healthcare organizations have realized that they are dependent on a huge environment under which they have relatively little control.
Thanks so much, Gene. Your perspective and your knowledge in this area is exactly why you're on this panel, because we have not been talking about this nearly enough. And your points about just in time and lean are really well taken now when we are short. So I look forward to various questions when we get to that stage, because I'm sure that this is front and center of a lot of our community leaders in health services delivery. So our next panelist is Jill Martin. She serves as Cedars-Sinai Medical Network Chief Operating Officer, and she's also Senior Vice President at Cedars-Sinai Health System. In her role, Jill oversees the financial and operational management of the medical network's 800 physicians and 1,500 staff, serving more than 220,000 patients at Cedars-Sinai. She also manages a number of supportive functions such as physician billing, provider contracting, human resources, network development, and managed care operations. And all this from home. No, she is with us tonight. I'm so grateful that she could make the time to be here, and I'm really eager to hear her perspective. Jill?
Thanks, Leah. Thanks for having me here tonight. Thank you for the introduction. So if you want to show the first slide, we kind of kicked off in mid-March with giving our physicians whiplash with the fact that we knew that we needed to figure out very quickly, in a matter of a few days, how to provide care that was socially distant. But that we also knew that we had a responsibility back to Cedars-Sinai Medical Center. We are a wholly owned subsidiary of Cedars-Sinai, that the physicians in the network had a responsibility to help plan for a potential hospital surge. So while we were trying to figure out our ambulatory clinics, it was also important that we were volunteering all of internal medicine for both urgent care work and inpatient ICU work. And at the same time, didn't want to lose sight of the work that it would take to be able to really transition to kind of the new world, the post-COVID world, knowing that we weren't sure when we were going to get there. So we really kind of launched planning committees for all three work streams. If you go to the next slide, in terms of providing that care in a socially distant world, we immediately dropped our visits to about 50% of our baseline. We focused on caring for the patients that had urgent and emergent needs, making sure that they were still able to visit with their physicians. I'll talk about kind of the virtual piece of that in a minute. And this is the ambulatory visits. At the same time, we had decreased our surgical cases and procedures to about 20% of the historical baseline. Again, deferring electives and focusing on the urgent and emergent. So while the volume was a 50% impact, the revenue impact was much higher than that, just given those deferrals of the surgical cases. Probably our largest hit specialty was surgery, with specialties like primary care and urgent care having less of a decrease, with an overall volume decline of about 50%. Our goal right now is to be able to increase those ambulatory visits to about 80% of our baseline. There's a lot of predictions that it'll take months before anybody can get back to 100% of your baseline. Not only because of patients' anxiety but also just the financial and economic impacts that the patients currently have. If you want to go to the next slide, while we reduced the overall visits to 50%, we did dramatically increase our use of telehealth, both video visits and telephone visits. They are now 80% of our total visit volume. I think pre-COVID, they were about 1% of our visit volume. We had the technology in place. We actually had a multi-year plan to really kind of roll telehealth out across the health system. And in a matter of just a couple of weeks, we were able to make that conversion. So as a wholly owned subsidiary of a large institution, we definitely were feeling the revenue, impacts. We were applying for, where eligible, the stimulus and the CARES Act, but we knew that we needed to go about cost control and cost containment at the same time. We had made a commitment to our staff and physicians that we, as long as they had volunteered for the surge, that we would not furlough anyone. So we had kind of the full cost on the staffing side, but we went to work on site consolidation. Given the volume of face-to-face visits, we didn't need to staff or supply the 85 different ambulatory clinics across the network. We reduced down to about 35 clinics. We asked the physicians for their flexibility in merging certain specialties together. So our cardiologists and pulmonologists were working for the first time in the same office. And we made sure to institute all of the appropriate daily monitoring for staff and patients, and went to more of a doctor of the day by specialty. So as we kind of look into the future and where we are today, you could go to the next slide, and where we want to be. We're spending a lot of time now talking about the silver linings. So in addition to telehealth and being able to rapidly deploy that and figuring out where it should stay in our future kind of infrastructure, we also think that there's actually been some good work on population health and managing the patient's care. We know that there's some preventatives that have been deferred that we have to make sure we are managing that backlog, but this actually opened up an opportunity for us for communication between specialists and primary care, and using that doctor of the day model to make sure that patients' questions and issues were being rapidly managed. On a go-forward basis, we definitely have the concerns about the ongoing financial impact, patients losing their jobs and possibly their coverage. I think in the state of California, we also need to mention the impact on the delegated medical groups, where we are acting as a payer and responsible for treating the COVID symptoms and tests, and really kind of taking that risk on through those delegated agreements. We are currently working on outreach to try to meet that baseline goal of 80% of our baseline. We are working through open referrals, wait lists, patients that have been canceled and or deferred, and making sure that we're doing that in a risk stratified way. So continuing to prioritize the urgent and emergent cases, and then kind of the immediate and routine. And again, with some of the patients' concerns about their own safety, making sure that we're messaging all of the precautions that we're taking in these offices so that patients feel safe when they're coming to see their physicians. I think from an overall kind of management and leadership perspective, what we've seen in some of these rapid deployments is really that it's a dynamic crisis, and that it's important for all of us to lead through these disruptive times. I definitely felt myself changing decisions on an hourly and daily basis, just as more information was coming in from the CDC or our local officials, and making sure that we remained flexible and started to be able to rethink how we treat our patients and how we communicate with our patients. So my takeaway from this time so far has really been thinking about how do you lead in disruptive times and how do you be resilient on behalf of your teams. Thank you very much.
Thanks so much, Jill, and I appreciate you sharing both your perspective on the technical element, but also as an individual leader and what's going on in your professional life as well. So that's very insightful. It's now my pleasure to introduce Ozzie Martinez. Ozzie is a Fielding School MPH alum. He is also the Chief Administrative Officer for Kaiser Permanente South Bay Medical Center, which provides healthcare for more than 260,000 members throughout South Los Angeles County. In his role, he sets the direction for medical group operations, which impact quality, the patient care experience, access to care, and the financial performance of the medical group at Kaiser Permanente South Bay. He's a real champion for the transformation of care, and it's unique in its integrated system model. So I'm thrilled that he's here with us tonight, and I'll turn it over to him.
Thank you, Leah. Appreciate that. If we can go to the first slide, that would be great. So thank you for the opportunity. I think it's great to reflect on what we've been experiencing these last few months of planning. And so from a Kaiser Permanente perspective, I think what I'll share with you is what I think has served us well. And I'll start off with first really speaking about our integrative delivery system. Secondly, we looked at a management structure that we were looking to identify how we can identify and escalate efficiently in order to drive our operational plans. And then lastly, just like Jill, I'll touch a little bit around how do we go past and really look at the future. We have some decisions that we really need to make around how we're going to operationalize the work moving forward. So we can go to the next slide, please. So I'm sure like many other healthcare organizations, the last 8 weeks have felt like a blur. And, you know, just to give you some perspective, the very first time I saw our modeling around a mild, moderate, or severe surge, it was overwhelming. I remember looking at our data, and the most severe surge really looked at something like what Italy was experiencing. And to give you perspective, we were looking at about 5 times of our capacity at our medical center. So for us, I was looking at establishing about 1,000 beds at our medical center, and about 400 of those beds needed to be ready for events. And when you think about that, again, just very overwhelming how are we going to do that? So the plan was clear. We needed to build hospital capacity. And the way to do it was leveraging our integrated delivery system and consolidating our ambulatory operations and being able to then, in essence, flip our entire model. So currently, you know, we were thinking about, hey, 90% of our care is ambulatory. That was going to shift. We're going to go to about 10% ambulatory, and everything else, 90% was going to shift to hospital care. And the purpose was clear. It was to save lives. And so in order to operationalize that, what we ended up doing was really getting our interdisciplinary team together and focusing really on 3 S's. One was looking at our space. How are we going to utilize that space to build capacity? Looking at our staff, our physicians, and our ancillary staff, and how are we going to support the hospital operation? And then ultimately looking at stuff, which really meant supplies, the things that Gene was speaking to around PPE, vents, et cetera. And we can go into a lot more detail as we go further in the Q&A, but we can go to the next slide. Part of what we needed to do was establish a more efficient manner to really look at our operation. So we consolidated and flattened our structure. And so what you see in this slide is an opportunity we took to look at all of our ambulatory operations, consolidated all those under ambulatory operations, acute care, and then we had 3 other areas. One, really looking at patient care services within the hospital, looking at supplies and equipment, and then ultimately operations and relations. And what we established here in consolidating our structure was that we were looking at an opportunity to make much more efficient decisions in a very timely manner. And so every single day, Dr. Carnes, our medical director, myself, and Margie, who's our senior VP for our medical center, start off with the huddle. And it's a 15-minute huddle with all of our chiefs, all of our administrative leaders. And really, it's for a few things. One, we understand that keeping open lines of communication with our front line is critical, especially in a time of crisis, because it's going to build trust. It's going to build a sense of accountability. And we would start off with a communication around what were the hot topics, things that were being escalated through the structure. After our huddle, we would move into a tier 1, which was our frontline physicians, who were the chiefs and our administrative leaders, in a conversation with their staff. And they would escalate anything that they couldn't address at their level. And then similar processes would follow for the tier 2, tier 3, and then ultimately at a tier 4. All of this was really done within about an hour, hour and a half. And the timing was perfect because we have an everyday regional command center call where we're able then to address anything that we needed to escalate to our regional command center by 10:30. And so in this process, we were really able to move very quickly in what we needed to do to build the capacity and provide the support to be able to operationalize our plans. If we can go to the next slide, please. So, I love this slide because it really starts to demonstrate, what it is that we have to look forward to. So I'll take a few minutes just to address how we're thinking about the work that lies ahead. And this really is looking at the variable demands of services. And it was adapted by Dr. Victor Singh, and one of our very own, actually, Stephanie Wally, who's also an alum of the executive program, was able to adapt this to us at South and what we've experienced. So this original forecast, as you see, is the surge that you see in purple. That was what we were preparing for, about 8-9 weeks ago, and immediately we had to build the capacity. What we actually experienced is the smaller purple wave, which looks a lot more flat. And, the social distancing has really flattened the curve. However, what we understand is that some of the loosening of the restrictions will most likely give us some possible future waves in the future. And so we got to remain vigilant. And with that, we got to also just be able to balance how we're going to get back to normal operations, if you will. We also saw this red line, which was really an impact to mental wellness of our staff, of our physicians, and also of our communities. If you think about our staff in the beginning, and even today, there's a lot of fear. And being able to address that, and as this really is shifting from this sprint, and the original forecast to much more of this marathon and this long haul, we got to be cognizant of how we continue to support our staff and our physicians as they go through this, and also our communities. Ultimately, the economic burden is going to be very heavy, and it's going to impact all of us. Some recent data that I just saw, about 3 weeks ago, we were at a much lower rate of people in the community being unemployed. By end of April, we're looking at almost 20% in California. And so that's definitely going to have an impact on how we provide care and how we take care of our patients. And then you have this green line that's really all the pent-up demand. It's really looking at our elective surgeries. How do we then start to plan to be able to provide the services to our patients in a way that's safe to them, it's safe to our staff, it's safe to our physicians, and we also are very cognizant of the PPE that is necessary in the case that we have some possible future COVID waves. Lastly, interruption to chronic conditions. We recognize that we have patients who have been, interrupted in their care because of what's going on today and the consolidation that we've seen. We have shifted now our care mainly virtual. In primary care, we were at Southfield, we were averaging about 30% all virtual. Now we're seeing over 96% is virtual. And then we've also shifted in our specialties. We went from about 10% to about 86%. Pediatrics, 10% to about 70%. So we're still seeing some face-to-face. And what we've done is we've operationalized our medical office buildings in a way where we have medical office buildings, if you will, and then we've turned our entire medical center into a place where we can expand our capacity to treat any patients that may be under investigation or COVID. We can go to the next slide, please. One of the things that I do want to share is, I think none of us would have thought, that the main disruptor that was going to impact how we provide care would have been this virus. We've always talked about new entrants in the market. We had talked about even competitors. And ultimately now, you know, it is going to be a new day. I think Jill spoke about the silver lining. You know, when we think about that, there is a huge opportunity for us. We got to be able to understand how we're going to be able to provide care to our patients in a whole different way. Healthcare consumption is going to change. It's going to be very different. We have shifted now to a much more virtual world, and we got to recognize that we have to meet the needs of our patients. We got to make sure that we provide ease, that we eliminate the hassle. We got to make sure that the system is efficient, that we eliminate waste, and that we make it efficient for our patients and for our own workflows, our own staff and physicians. And ultimately, we got to understand that we got to make that emotional connection with our patients, because that's going to create the loyalty and it's going to create that sense of trust that they will have in the care that we're providing for them. Quality continues to be our true north. We continue to provide evidence-based medicine, but ultimately we got to be able to be transformative in how we provide care to our patients and reduce this cost structure. And so we do have to look very differently now at how we're going to look at our operations in the future. I also want to just end with saying thank you. I'm incredibly grateful, and what I've noticed is this community that has just come together. I can round throughout our medical center and say thank you to our physicians and say thank you to our staff. But when it comes from our patient, when it comes from our community, it means so much more. And I have really seen that across the country, across the globe, and it has really meant a lot. And so I look forward to a great Q&A session. Thank you for the opportunity.
Thank you, Ozzie, so much. Wonderful comments. If I could ask my panelists to actually put their cameras and their microphones back on, we'll go to a gallery view where our audience, who has been sending us already in the Q&A wonderful questions, will be able to launch right into those. As you can imagine, some of the questions have been coming in as each one of you have spoken. I'd like to start with one of the earlier ones, which, Jean, this comes back to you. It's from Carolina Rodriguez, and she says, unfortunately, in an educational setting, purchasing PPE has not really been a priority. And now obtaining supplies is challenging since we don't have a supply chain. Any thoughts on how we can tap into local hospitals and systems?
Yeah, I mean, I think there are a lot of ways of tapping into local hospitals and systems to find PPEs. I have been receiving approximately 5 emails a day of individuals who have PPEs to sell. Had no idea what to do with those when I started. Started just sending them to different folks. I sent them to some friends at Kaiser, sent them to some friends in New York City at New York Presbyterian. But there are a number of exchanges that are evolving. An organization, a company called Resolink, which is located in California, has put together an exchange that hospitals can subscribe to. Initially, it was free. I'm not quite sure if it's not a subscription at this point that links up buyers and sellers. A Global Health Exchange has done some of that. But what's actually more interesting in New York, for example, the New York Hospital Association, GENIHA, which is the Greater New York Hospital Association, has really acted as a compiler of products for the New York metropolitan area. And that was really my comment up front, that the commons seems to have dissolved, but we see some new commons evolving, and some of those are actually web-based commons to be able to get to those materials.
Great, thank you. What is the new normal for Jill? What is the new normal going to look like when we go to doctor's offices? Either Jill, Ozzie, or both of you. We've talked a lot about this crisis mode and this disruption, but do you have a crystal ball and can sort of guess what it will look like?
Yeah, you know, right now I think that it looks very clinical, right? So we had spent a lot of time really kind of focusing on our patients' experience, redesigning our facilities so that they were, you know, less kind of traditional doctor's office and clinical, and more of a place to, you know, gather and, you know, manage your health needs. And right now I think we've reverted a little bit to clinical. masks and temperature checking and, full, you go to see your doctor and there's these, full PPE. I'm sure scary for kids, for the elderly. So we have to find the new normal. It probably isn't going back fully to where we were. We definitely hope that the new normal continues. Some options in telehealth, I think for post-ops in orthopedics, not to have to, crutch into the doctor's office and be able to do your post-op via video visit sounds great for the patient and for the surgeon. So I think the new normal will definitely include telehealth, and we need to find the right balance when a face-to-face visit is needed or a procedure is needed so that we're safe, but that we're also able to kind of ease any care anxieties and really kind of create a great experience in the new normal for the patients.
Yeah, I think what I would add is the shift is really going to be care at home. It's really around life integration. Where can we meet our patients where they're at? And the virtual ecosystem becomes so much more important now than ever. And so as we look at this again, I think some of the benefits are really around, ourselves and some of our specialty departments where we never thought we'd be able to do some of the virtual care that we're doing, being able to do that. And it's an incredible shift in your mindset, especially for our physicians and for our members who have never experienced, having to do so much virtual care today. And it's not to say that we still don't have to see patients face to face. We will, and we have to. But there is a huge opportunity, and care at home, care as a true venue of care is something that we have to really be thinking about.
Yeah, and there's so many analogies being driven with this right now, whether it be work from home, whether it be education from home. People are rethinking all of these business models, I know. An interesting question came in that kind of combines both the supply chain as well as the delivery system. I have got to read the small print here. It says a lot of the leaning, right? The just in time and the lean supply chain, a lot of the leaning of supply chains has been a response to deteriorating margins for hospitals. How do we reconcile Dr. Schneller's comments about changing the supply chain dynamics with the financial viability of hospitals and not holding all that inventory? So either Gene, your perspective on that, but also from the delivery side, this has been a technique that's been used for really keeping that inventory minimal.
So one thought I've had is that we need to redefine community benefit, particularly from a not-for-profit perspective. And I've looked at a lot of community benefit papers from not-for-profits for IRS. And one could see a collaborative way of doing that across a community, across a region. And so I think that's one way of financing. I think we need to take a financing perspective. The government's going to do some of that, but I think within regions, hospitals themselves can do some of that and think about how to share. There are also organizations that are developing technologies to allow people to share, to move equipment around. We saw equipment move, obviously, from Seattle to New York, but we really aren't very expert at doing those kinds of things. So how do you recreate the commons? But more interestingly, how do you finance that? And one would be to try to redefine community benefit. That's one thought.
I think what I would add is redefining our own operations. So, a simple example is what we've been doing with our COVID patients is starting to cohort our patients in a way where you're reducing your use of PPE. So I think, we're starting to understand that when we have limited PPE and we got to be very vigilant, we got to come up with different ways on how we operationalize the work. And so we have our ICU and we have our section for our ICU. We've come up with innovative ways to be able to reduce and eliminate unnecessary use of PPE in our emergency department. We've done some cohorting of patients as well. We've cohorted patients in our ambulatory settings. And so you're then being able to provide the appropriate PPE for our staff, because ultimately the safety of them, the safety of our patients and our physicians is critical. And so you want to provide the appropriate PPE, but you also have to understand that, we have to be much more vigilant in our appropriate use of it.
Leah, let me just come back and make another comment, and that is, I don't think we've been nearly as demanding as we could be of our distributors and our purchasing organizations. I mentioned that we've outsourced that, but we have frequently outsourced that without really talking with them over what kinds of reserves are needed. And we've talked to them about saving money, but not the development of those kinds of banks of reserves. And so I think, in a sense, by outsourcing our risk, we've assumed somebody else is taking care of that. And I think we need to begin to own some of that. And I think many provider organizations have learned to do that. And that's one of the good outcomes, perhaps, of the crisis.
Yeah, I was just going to add, I love Jean's comment on community benefit. I think that that's something that the Hospital Association should consider. The other thing that I hope is here to stay is reprocessing.
Yeah.
If that's, you know, a well thought out process and something that we all can be doing to conserve PPE, then it should continue into the future. And the last thing that I'll say is that I am worried about the hoarding. I think that the initial reaction from most purchasing agents will be that they never want to have to go through this again, and they will start to stockpile. And so figuring that out kind of across the health systems will also be important.
Good. I'm going to change the topic a little bit to a question from Nicole Haskell, who's also an alum of the Fielding School. She writes, I'm curious how Kaiser and Cedars-Sinai is thinking about antibody testing. There's a lot of buzz about organizations using it to identify employees who have been infected and then using that information to create processes. I also know there's a lack of understanding in what it means if you actually have the antibodies and whether you can be infected again. What do you think about the value of this and having people either be considered safe at work or be considered still potentially in sort of a danger zone?
Yeah, so it's interesting. If you don't mind, Jill, I'll start. There is a lot of work going on right now, and actually Dr. Nancy Jen has been doing a lot of this. She's our Executive Medical Director for Quality in partnership with Mayo and in partnership with Gilead, actually, in some studies. So there's a lot of pilots, if you will, that are going on, but we just don't understand it enough to really understand the impact that it will have. But we are actively partnering with organizations to try to identify the impact. What she has shared with us is, you know, as we're looking at some of the antibody work and what we've seen from other countries, especially for MERS and SARS, that, you know, as we're looking at this, it's still difficult to determine what the antibody is going to look like. It's difficult to know the immunity of someone, you know, whether it's going to be a year or 2 years, and there's still a lot of research to be done. But we're trying to partner as much as we can with currently 2 active pilots with Gilead and also with Mayo.
Yeah, I agree that there's still a lot to figure out here. The one thing that we have been tracking, in addition to what Ozzie said, is that, you know, how will the health plans and the payers consider the antibody testing? And I think we might have some participants that work for the payers and can speak to this, but my understanding is that, you know, medical necessity is still the question. And that, you know, some of the medical policies will be covered if only if it's deemed medically necessary. And so how, you know, this all kind of falls in between the payers, possibly, you know, some of the local or state governments in terms of, you know, who would be ultimately financially responsible. I think that, you know, the clinical and the financials will have to balance on it.
There's a really good follow-up question to this that has to do specifically with the workforce and the change also of the experience, and comes from Tammy Graham, and she says, do you think that social distancing will affect the way facilities are designed and the way care is delivered beyond the telemedicine experience? But when there has to be this, without the knowledge of antibodies yet, as we go forward, will there be some sort of social distancing or change in the way the interactions work?
Yeah, I definitely think so. I made the comment earlier that we had, you know, spent a lot of time in construction in redesigning, you know, what we called our transformed practices. that really kind of focused on the flow of the patient and the experience of the patient. And it did end up putting kind of that back office in a pod together, sitting pretty closely to each other. And we have to rethink that now. You know, we have these beautifully designed offices that we very quickly put sneeze guards up in all of the check-in stations. You know, it doesn't necessarily flow with the rest of the design. And so I think that it'll be important, similar to the earlier topic, that as we try to define the new normal, in addition to the virtual, you know, health, that when we do have to come together, not only will we need to focus on kind of the flow of the patient through the healthcare system physically, but also making sure that our care teams are working in, you know, physical space that's going to make sure that they stay well protected. I told a number of physicians and staff that work at our urgent care with, you know, full PPE on for their 10-hour shift, that it's hard for me to wear a mask in the grocery store. So I can't imagine how they're currently doing their jobs under that full, you know, armor, and that we're going to have to, you know, think about how do we continue to protect them, but also, you know, make sure that we are meeting, you know, the needs of the patients as well.
Great. Here's a big question that will have us all thinking here. It's a combination of thinking from Jim Eckler and Bruce Gilmore, sort of a combined question here. What new types of relationships are going to be needed between clinicians and administrators, supply chain, the whole ecosystem, to manage the next pandemic? How can we create an environment that's really collaborative across healthcare organizations, and what have we learned?
You know, so maybe I can start, because I think we've experienced some of it. You know, as an integrated delivery system, we have a hospital health plan, and then, you know, I work for SCPMG, the medical group, and I would say we felt we had really strong relationships, and this has brought us even closer. And I think the interdependence that we have seen across the organization, and it's not just in Southern California, but it's across the enterprise. As we looked at this work, I think we have learned a lot around flexibility, being nimble, and what we've been able to accomplish in just the last 2 months. You know, it's pretty incredible. And what I would say, what it's caused is also this synergy with the community. So you might be aware of you know, the Navy ship who was just down the street from us, the Mercy. Also LASH, right, which is the Los Angeles Surge Hospital. And that was in partnership with Dignity Health, California, and LA County, as well as Kaiser Permanente. And so being able to address some of this work together is really gonna make a difference. And I think that speaks to also how the community has seen the work that we get to do and the privilege that we have to provide healthcare. And I can definitely see, again, going back to the opportunities we have to partner in a whole different way. We are, in a way, blessed that we're integrated, and so the work that we do related to PPE, you name it, we're in conversations directly with those that are running those programs for our organization, even though it's more of a KFH function. But we're able to partner with them directly, so it makes it a lot easier. But I think there's so many more learnings to continue to build these types of relationships across our community, because I think what we saw and what we're seeing is this impact of all of us coming together to take care of our community, not just our members, but our community as a whole.
I know that both Bruce and Jim have worked in healthcare supply chain, but supply chains in other industries. And one of the things that we've seen is that the supply chain people in healthcare almost never talk to the supply chain people in their manufacturers. And it's been really interesting, and maybe there's something to learn from that, in that, you know, GM was able to go out and produce ventilators very quickly. I think they sourced something like 1,400 SKUs, stock keeping units, overnight. And that's because they're so good at working with their suppliers upstream, and we never do that. And so I think that, you know, the suppliers who are manufacturing, whether it's for Medtronic or whether it's for J&J. You know, in healthcare, we talk to the salespeople. We don't talk to the supply chain people. And we need to understand what drives each other in a new kind of way.
Yeah, I'll just add that I think what has helped us in this pandemic, and I hope there's not another one in the future, but in this particular one, has really been the collaboration between what we call the dyad structure. So the physician leader paired with their administrative partner. And while we are an integrated system, we have definitely seen more collaboration between the specialties, between the primary physicians and the specialists, coming together with their dyad partners to really kind of learn from each other. The level of sharing of best practice in the past 6 weeks has been at a rapid level, rapid pace. Doctors are, logging into webinars and sharing their personal experience with telehealth, how they've experimented with risk stratification by specialty, how they've experimented with various forms of outreach, both telephonic and through some of our patient portals. So that level of collaboration between physician and administrative dyad partners, and then those teams across multiple specialties, in our case, multiple medical groups in our medical network model, is something that I think everyone right now is feeling the, not only the importance of it, but the benefit from it. And so, if we all go back to kind of our pre-COVID level of busyness and distractions, how to be able to maintain that level of communication and collaboration, I think will be important for the future of, the success of the healthcare system.
As a professor of strategy, healthcare strategy and innovation, I never, as one of you said, never would have guessed that a virus would have done it, but sometimes it's the most unsuspecting thing that is going to hopefully change us for the better. So I'm aware that we're nearing the end of our time. I want to respect that people committed to an hour here. Everyone is busy and it's the end of the day for most people, and others are still working hard. I want to thank so much. I'm sorry I couldn't get to all the excellent questions and answers. We'll share these with the panelists if anyone is interested in following up, as well as we said, you can find more information on our website. I really want to thank Dean Brookmeyer for his vision in starting Fielding Focus. It's the same sort of thing. We're trying to be innovative and reach an audience that's hungry for this information and hear from people who are experiencing it just like our participants have been. Thank you so much to Eugene Schneller, Jill Martin, and Ozzie Martinez for being willing to take time out of their busy schedules and share this with you. I really respect the work you're doing and also really appreciate you giving back to the community. I hope all of you join us again next week, Tuesday, May 5th at 6 p.m. when my colleague, Professor Jessica Gibson, is going to be leading a discussion about COVID and our vulnerable populations. As we know, it's disproportionately affecting them. And here in LA County, we are all the more aware of the inequities in the system and our vulnerable populations. So until then, thank you so much for joining us. Visit our website, ph.ucla.edu. There's been some questions about the slides and sharing those. We'll make sure we get a follow-up out to all of you who have participated today, and to thank you and get you some additional information. So thanks very much. Have a good evening. Stay well and stay safe.